Unit. Yes, Professor, the floor is yours. Thank you very much, Attila. My slides will be English, so I'm going to speak in English so that I'm not going to be confused, but every now and then I'm going to switch back and forth. So I would like to apologize for that beforehand. Well, as you get older, your memory gets worse, so it's good to be bilingual. So I will try to switch back and forth between English and Turkish. So I only have 20 minutes, so I'm going to speak fast because I was expecting 30 minutes, but still we need some time for a Q&A session at the end of the day. Because we also want to learn what you're doing in clinical practice.
Comprehensive presentation from Professor Hook about the academic background, research etiological background, and the classification, nosological background of the eating disorders. Now we are going to talk what we can make use of in clinical applications. Because I assume most of you are clinicians, psychiatrists, and you have patients coming to your clinic, and you need to do something about it. And our goal is to help you to do something good, the utilitarian therapy, right? To help people. That's most of us, all of us initially probably went into medicine, the desire to be able to help other people. And one other issue I would like to emphasize, the eating disorders overall, in terms of prevalence, will increase in Turkey as well, and it is going to continue to increase in the emerging economies, emerging countries. And it might have stabilized or it may stop increasing in the United States or European countries, but you are going to see more and more of these patients, some severe cases, some clinical, syndromal, subsyndromal cases. And you are going to hear from your colleagues, families and friends, our daughters, most commonly in females, unfortunately, struggling with these. So what would you recommend, doctor? So it is an interesting emerging area. And obviously the connection or some sort of relationship with the obesity makes it a public health issue as well. Okay, so let's start. These disorders do have a high social impact because they impact mainly younger students. In the US, we see now, I have, I think, youngest 11-year of female presenting a daughter of a physician to me for getting treatment after she had multiple hospitalizations. So particularly, it used to be more college, university students, but now it is more high schools. And two areas they kind of study is when kids start the high school and being teased by his friends, that may trigger starting to diet, which may turn into an eating disorder eventually, and also gaining 15 pounds, like 7-8 kilograms in the first year of college. They call it in the US freshman 15, and that weight gain in the first year of college usually triggers the dieting in the summer, and I see a lot of people struggling after that eating disorder symptoms, restricting, significant weight loss, binging, purging, fear of weight gain, etc., etc. So the comorbidities are very important in eating disorders. These disorders can be deadly. They are among the most fatal psychiatric conditions. So you should be able to recognize these are serious conditions. They are rare in severe forms, but it is important to intervene. The treatment is multidisciplinary, multidimensional, psychotherapy, family therapy, nutritional rehabilitation is very important. And obviously there's a role for drug treatment. That's the main topic of my presentation. So that's why I'm switching to GR a little bit faster. And we expect the medications will have the core symptoms of eating disorders plus the comorbid conditions. Because comorbid conditions are very high in eating disorders, more than 50%. Mood disorder comorbidity, close to 50%. Anxiety disorder comorbidity, substance abuse disorders are very common. We'll have more slides on that. So these are the common symptoms, medical symptoms you will see in anorexia. This is continuation, basically. And that will be available for either through the organization, so I will go fast here. In the bulimia, because of the binging and purging behavior, obviously we have more electrolyte abnormalities, dehydration, dental decays, erosion, gastroesophageal symptoms. And ipecac abuse used to be very common in the United States to induce vomiting. You know, in the old days, it was recommended to induce vomiting after overdoses or being poisoned with something. It is removed now from the kitchen, medication supply rooms in most households in the U.S., but that might be an issue in some countries. So if you have patients abusing these, that can cause cardiomyopathy. So continuation of the side effects again here. Now, the main medication group, we have most evidence in eating disorder treatments are antidepressants. And primarily the evidence is mostly for bulimia nervosa, some for binge eating disorders. Now it's a formal diagnosis in DSM-5, and there's some evidence for anorexia. Here, I already mentioned the mood disorder comorbidity is very high, so that's why we need to keep in mind, don't think these individuals would not benefit from medication, because always screen for comorbid mood disorders, depression, dysthymia, history of trauma, etc. So personality disorders is another one very commonly we do see in these individuals. Obsessive compulsive traits of the personality, borderline personality traits or disorder formally, and relationship problems. There is a saying actually we do use in daily practice. Eating disorder usually is a symptom of some sort of relationship problem. And at the core, it's the problem the patient has with the food, relationship problem with the food. Now, tricyclics, and there are some studies, but basically we cannot really use them because of the high cardiovascular contraindications, arrhythmia risks, QTc prolongation risks, and there are the findings for both SSRIs and tricyclics. They are not very helpful in regaining the weight that anorexic patients do lose. Fluoxetine, this is the medicine, 1987, as you remember, came to the market, and this is the most evidence we have in treatment of bulimia nervosa primarily, and binge eating disorders, and also in the chronic phase of anorexia nervosa, and most importantly, co-occurring comorbid conditions that you need to remember if you have a patient with major depressive disorders or anxiety disorders. You may comorbid with eating disorder, bulimia or binge eating disorder, you may choose fluoxetine first if you go just pure evidence-based medicine. But that doesn't necessarily mean other SSRIs are not as effective. It's just they are not really as comprehensively being studied yet. Important thing here, the findings basically reduced binging, purging, and improved mood and anxiety symptoms. When we talk about binging, basically somebody should have a loss of control of the self during the binge eating period. You will see a lot of patients, particularly anorexics, they will say, I had a binge. You ask them how much they ate maybe a quarter of their regular portion, but they perceive it as a binge. They still have that fear and they go and purge afterwards. So really, if you go just restricting, binging and purging, initially you see like a subsyndromal, subclinical issue, dieting, then starts with restricting to clinically significant degree, and after that, when the control becomes more difficult, a lot of patients starts to binge and purge and then binge, and overexercise, another common core symptom of eating disorder, in addition to obviously use of laxatives, diuretics, diet pills, etc. I think we went back. So we already mentioned this. There is some studies about citalopram, but there is the dose limitation here now with the cardiac risk more than 40 milligram. So you need to be careful, and that usually limits my use in my clinical practice because you do need higher doses in eating disorders. And fluoxetine 60 to 80 milligram, very rarely 100 milligram are needed. Sertraline is, and fluoxamine is another one. There are some studies about that, which is not commonly used in daily routine. Okay, we already mentioned this part. The high attrition rate here. By attrition rate means basically churning out. That is, in 5 years, approximately 58, actually that's, I think there is a mistake there, 58 weeks. That should be longer, it might be months, I don't recall. But in that period, maybe one of my colleagues might correct me if they remember, 83% of patients are lost to follow-up, like they couldn't stay in treatment. So basically you really have 1 out of 5 patients you still have in treatment after that period. And that was even higher in the placebo. It was a randomized controlled trial. There was still benefits using the fluoxetine, but in these patients it's very difficult to keep them in treatment. Although you may say, in which disorder in psychiatry is it easy? It is easy. Okay, so the findings again: decreased number of binges, improved symptoms of depression and anxiety. When there are 2 meta-analyses, and that adds up to more than 600 patients, basically SSRIs were favored over the placebo in terms of both gaining more weight and decreasing the effect of comorbid conditions. Fluoxetine is an SNRI, and it was found to be helpful decreasing the binges, body weight, and depressive symptoms. Now, antipsychotics. This is another group we end up using. It is very understudied again, but the important thing here, as everybody knows, they do use dopaminergic system, and also with atypical antipsychotics, they do interact with the serotonergic system in addition to dopamine system. Now, they do help with these symptoms in the eating disorders, because in these individuals, sometimes they do border with psychosis, or pseudo hallucinations, or pseudo delusions, mini psychotic episodes, as we call them in borderline personality disorder. You will see those. Second generation antipsychotics, we do have more evidence, and primarily the studies are done with olanzapine, and as clinicians being practical people like myself, we do see a lot of adverse event as a weight gain in other psychiatric conditions. Why don't try olanzapine in anorexic patients, right? And these small studies found some benefits. Now here, for the young colleagues particularly, I want to emphasize, olanzapine dose was 10 milligram. FDA approved maximum dose is 20 milligram, right? But we do go to 30 to 40 milligrams in clinical practice. Now, chlorpromazine dose is 50 milligram only. So this is a common trick you would see in some clinical trials. And there are different. One is market reasons for those, because newer agents, they are being promoted more, and clinicians tend to study them more, and sometimes the dose mismatch is possible. The equivalent dose of olanzapine, if you compare to chlorpromazine, should be, if it is 500 milligram average dose, equals to 20, so we should really go to higher dose here. But you can make a counter argument, well, maybe we should say olanzapine can be 40 milligram maximum dose as opposed to 20. But I want the young colleagues to be aware of this. When they do read the literature, this is commonly, the dose mismatch is a common trick. You need to be careful. Now, in another olanzapine study, started with 2.5 milligram per day, went to 5 milligram average dose. There was 30 patients, and the benefits were more in the olanzapine group, gained more weight, depressive symptoms improved more, aggressive symptoms improved more. Another small olanzapine study in anorexia, and as you see, OCD symptoms decreased. Not surprising, right? We do add atypical antipsychotics, risperidone or olanzapine, in treatment-resistant OCD. Now, the summary for second-generation antipsychotics may reduce psychiatric symptoms associated with anorexia. They may promote weight gain, but it is very difficult to persuade these patients to accept those medications. They say, I don't have schizophrenia, I don't hear voices, I'm going to gain weight. That's their biggest, and they will know before you tell them, or in their second appointment with you. If you say, well, they will never know. These are smart patients. These are, I do remember having an OBGYN doctor, emergency doctor, nurses, clinicians, PhDs, a lot of basically high-achieving individuals struggling with eating disorders. So you really need to be honest, open, but also you need to be persuasive in your clinical skills so that you can convince them they need treatment. Okay, the important thing on these slides, I guess, the side effects part, I'm sure most people know and can find out easily. I want to just emphasize the part based on my clinical experience. And the part is there is still very few evidence for guidelines for eating disorders. I'm going to have a slide. There are only three guidelines really so far in the literature. So I'm hoping young colleagues here, they are going to do more studies, more randomized controlled trials, hopefully improve the research quality in Turkey and in the surrounding region. And we are going to see, for academicians, psychiatrists, basically specializing in eating disorders and contributing to the field of psychiatry. Now, just quickly, anti-epileptic drugs, right? We do use them a lot in bipolar, in other psychiatric conditions. So valproate and pregabalin, they do cause weight gain. Very rarely we end up using them except some comorbid conditions. Topiramate, zonisamide can be very helpful in bulimia nervosa particularly and binge eating disorder. We have significant evidence so far, and I am hoping there will be some more randomized controlled trials lasting longer periods. Now, anti-binge eating, anti-purge features, weight loss properties, these are important, and a lot of patients struggling with obesity end up being put on those two medications. You need to be careful with the side effects, though. I think in the next slide, we have that, one more slide maybe. So the dose is important here. Most commonly, I end up at 100 milligram per day topiramate dose, and it does help with the binging again, purging behavior. And weight loss is really secondary in my practice because we do focus on primarily eating disorders, not necessarily obesity. And in binge eating disorder, we do go higher dose with topiramate. But at 300 milligram, which is a pretty good dose, it did show improvement in psychiatric comorbidity because if you ask average psychiatrist, topiramate is a bad mood stabilizer, right? It can have a lot of side effects. But at least based on Susan McElroy's study, who is a reputable researcher in the US, that did help. Zonisamide combined with CBT, that was very helpful, at least, well, helpful, not very helpful, but that tells us we need to explore that further. Now the side effect part with both agents. Memory problems, confusion, fatigue, impaired concentration, irritability, metallic taste in the mouth. So it can be a burden really to have the patient. What I do is I really start low. Sometimes 10 milligram, 12.5 milligram, with 25 is the lowest dose for topiramate. And increase it very gradually to minimize that side effect risk. So I see here my time is running short, so we are gonna get a little bit faster. If you are still with me, if you are not asleep there, sleep. Orlistat is a great agent for people who want to lose weight. It has been shown to be helpful in binging behavior, binge eating disorder. The problem is side effects. Fecal incontinence, passing gas, heartburn, very tough for most people, and most people don't like to use it. But if you have people who haven't tried it, I think it's a good agent, very limited side effect profile other than difficult to tolerate ones. Atomoxetine, ADHD medication, non-stimulant ADHD medication, right, have been proven to be helpful in binge eating disorder, at least in one controlled study. The dose was kind of on the high end here, as you see. Dry mouth, nausea, insomnia, headache, nervousness was side effects. So in the acute phase of anorexia, really we don't have much evidence any medication works. The food is the medicine at that phase. The body is really in a catabolic state. You need to stop the weight loss, have the patient gain the weight back safely so that we can have enough receptors in the brain for the medication to target. Avoid bupropion. Wellbutrin is the name, I think it's the same here or similar. Because of high seizure risk, this is just like clinical pearls. I do see patients in my practice being on Wellbutrin, even they do have binging, purging behavior. And you may say, well, just binging may not create that, and there is evidence in treatment-resistant individuals who can tolerate other antidepressants, if they don't have any purging, and that includes overexercise, use of laxatives, and vomiting, then you may say, well, that's a good option for this individual, but just get a second opinion, get a document well. At least in the USA, you know, we always think about being sued. It is, but also it is good practice to consider all this. So, olanzapine, risperidone, quietapine, there are some evidence now with quietapine and olanzapine. And risperidone I do use in my clinical practice if I can convince the patient. Food is the prescribed medication. That's the part I already mentioned. Now, insulin-resistant, those side effects, I think we'll go here since my time is getting shorter. I don't know how much Professor Attila will give me, but I want to emphasize a few more things on the next few slides with his permission. Benzodiazepines can be problematic because some of those individuals do have substance use problems. And you need to be careful. And there's really long-term, other than comorbid conditions, they are not helpful in eating disorders. Gabapentin can be a good choice to have with anxiety disorders. Antihistaminics sometimes, hydroxyzine is sometimes we do use for insomnia, anxiety, if there are comorbid substance use. Vitamin D with calcium. Now, just so you are aware, in women there is no evidence, but for men taking just calcium can increase risk of atherosclerosis. There is recent evidence. So I do recommend to my patients, and mostly they are females, add vitamin D to your calcium dose because osteoporosis, osteopenia is a big problem in this population. So you need to replace that calcium, but don't forget to add vitamin D. Sometimes zinc supplements, there is some evidence that was helpful. Now, putting these patients on estrogen replacement therapy, as most OB/GYN doctors do, may not be a good idea. At least give them 6 months after they reach 90% of their ideal body weight, so that they don't get missed sense of, oh, I'm okay, I just recovered and my period is back, but it is back due to oral contraceptive medication. All right, so we can go these parts. I think I have a couple more slides there. Now, this is again younger generation who wants to focus on research more. Based on my reading, basically we need studies lasting longer, randomized controlled studies. Obviously, it is much easier in the clinical practice to do open series. You can start there if you are early in your residency, but try to go into more sophisticated designs so that you can improve the quality of publications in Turkey, as Psychopharmacology Association is trying to promote. Now, let's go to the next one. These are the current clinical guidelines to treat eating disorders, to my knowledge. Only 3. CBT, family therapy, and some mentalization therapies. Mindfulness therapies are the main source of treatment, but medications are important. I think we can skip this one. Basically, summary is drugs have limited role in treatment of eating disorders, but their role is still crucial because more than 50% of these individuals do have another psychiatric condition, mostly mood disorders, anxiety disorders, substance use disorders. So it is important to consider medications and to know how to manage that. For comorbid conditions, we have remarkable efficacy of the medications. For substance abuse treatment, we'll have another session on that, particularly substance abuse problem in Turkey, and on Saturday at 4 o'clock here, a joint session with Social Psychiatry Association, American Social Psychiatry Association and Ortho Psychiatry Association. So we can talk there more. But it is important to use medication in substance abuse disorders as well. It is another under-treated area. And I think ideal pharmacotherapy should include not just to target the core symptoms of eating disorders, but address the relapse of the disorder. These are chronic conditions with a lot of relapses over lifetime. I do see patients. I had a 75-year-old or 70-some-year-old grandma developed anorexia. She was the oldest patient I had. She was fun to work with. She has a good results, but don't say this is just younger generation, because some people, unfortunately, cannot grow out of these conditions. This is available, will be available, so we'll just skip it. It's just summary of slides, and I think I will conclude. Thank you very much for your patience. Thank you, Professor Attila, letting me finish.
Evet, Profesör Doktor